All guests have been muted.
Hi, this is Dr. Christine Hunter again. I was introducing Dr. John Steiner, and apparently we had some technical difficulties. So all right, so we're going to give it another try, and I'm going to do a brief introduction for Dr. John Steiner, who we're very pleased to have with us. He's been the Senior Director of the Institute for Health Research at Kaiser Permanente, Colorado since 2008. He currently serves as Chair of the Kaiser Permanente National Research Council and is Chairman of the Governing Board of the National HMO Research Network. He did his internal medicine training at the University of Colorado and received his MPH from the University of Washington. Prior to 2008, he was a tenured professor in the Department of Medicine at the University of Colorado School of Medicine and the director of the Colorado Health Outcomes Program. Dr. Steiner is the author or co-author of over 200 publications that reflect his research interests in access to care, health disparities, prevention and treatment of cardiovascular disease and diabetes, medication adherence, and research training. Nana, do you have any technical things that you want me to convey before we get started?
Everything is on the side of the screen.
Okay.
To look on the side of the screen for all the information.
Okay. If there are any technical issues that you need to be aware of, look at the left side of your screen, and any information that is needed will be posted there. And well, without any further ado, I'll turn it over to Dr. Steiner.
Well, thank you very much for inviting me to speak today. What I'm going to do today is to provide a somewhat different perspective on the perennial question of medication adherence, which is a perspective that's really been honed by the 5 years I've spent working inside an integrated delivery system at Kaiser Permanente. So the title of today's talk is Adherence, the Delivery System Perspective. This work is supported by a grant from the Agency for Healthcare Research and Quality, and I have no other disclosures to make. As everybody on the call knows, long-term adherence with chronic medications remains a major problem. The widely quoted statistic is that fewer than 50% of individuals prescribed a new medication for diabetes or other chronic health conditions continue that drug for even a year. I've been doing adherence research for 25 years myself, and we've been quoting the same statistic essentially for all that time, which really raises the question of whether this is an intractable problem at the population level. So what do I mean when I say that the delivery system has a perspective on adherence? I think fundamentally it starts with the fact that an integrated delivery system like Kaiser is responsible for comprehensive care of a definable population. For example, in my own institution in Kaiser, Colorado, we care for 100,000 members with hypertension and roughly 30,000 with diabetes. If you believe the prior slide, that means that probably half of them will be non-adherent. So how do we deal with adherence at the population level? We need to make use of measures that are widely available. We need to think about interventions in terms of their scalability. And I think this has been a particular problem in the adherence field, where many one-on-one intensive interventions that have shown efficacy on the small scale may not be sustainable. Effectively, we often work with the formula I show here, which is that a small effect size times a broad reach may maximize the benefit in a large population. So, are these delivery systems really responsible for the behavior of their members with respect to adherence or other kinds of self-care considerations? Medicare has decided that they are. The Medicare STAR program, which is a quality measurement program for Medicare Advantage plans like Kaiser Permanente, has provided financial incentives for high quality for many years. In 2012, Medicare began a fascinating experiment to add adherence measures to their list of quality measures. And they now have prescription refill adherence measures for oral hypoglycemics, antihypertensives, and lipid-lowering drugs in certain situations. To achieve the recognition as 5 stars, the highest Medicare rating, these plans have to show that 75% of qualifying beneficiaries achieve 80% adherence or higher with these classes of medications. So effectively, the implementation of adherence quality measures by Medicare really does incentivize delivery systems to take responsibility for changing patient behavior on the large scale. As I've recently written, efforts to improve adherence at any level, I think, are impeded by 3 misconceptions, and I'm going to spend a bit of time reviewing these. These are the common misconceptions I think the field faces. The first is that adherence is a single behavior or construct. The second is that easily obtainable sociodemographic or clinical characteristics can actually accurately predict adherence. And third, that individual frontline clinicians can improve patient adherence on their own. So to the first misconception, that adherence is a single behavior. My view is that it's really a, let's go back, please. You know, we're going the wrong way here with the slides. It started advancing on its own. To the next slide, please. Yes.
Oh,
sorry. No, the previous, the next one. There we go. The Medicare STARS program has chosen to use a measure of medication refills as its primary adherence metric because it is widely available in integrated delivery systems. But that decision is commonly criticized by people who claim that the refills are not an accurate measure of adherence. And I think this is an oversimplified critique for the following reasons. In my view, adherence is a cascade of behaviors that starts with seeking care and then moves to keeping appointments, filling a prescription, the behavior that Medicare measures, then of course taking the medication while engaging in other self-care behaviors such as diet or exercise. This is particularly true for common chronic health conditions like diabetes. Should I pause for a minute here?
Yeah, I think we need to pause for a minute. I understand the slides are not showing up on your screen, so we're going to try to figure that out. Sorry about the technical difficulties. We'll get started as soon as we can.
They should see it. I don't know why they're not seeing it. I see it. No, if you use that, you're going to have to use your data.
No, I saw it before. But now
I wonder if we can unmute the line and see if some of the other people can see it.
They can talk to me.
Should we ask them if they
they're
can?
able to see it. Everyone can see it. It says the slides are visible. Yeah,
Okay.
They can see it. Because I'm watching here too.
Okay, great. So again, our apologies, and we'll continue.
Okay. Yeah, please do let us know if you have any problems seeing the slides. It seems to be sort of intramural to NIH at this point. Okay. So in any case, I was just saying that adherence is a cascade of behaviors, and I went through those. So let's go to the next slide then. And this is an example of what a patient with type 2 diabetes, hypertension, and a lipid disorder would need to do to be fully adherent with all the recommendations that we tend to make for their treatment. We make recommendations about diet, which they have to implement for 3 meals a day. We ask them to see their clinicians a certain number of times a year, to refill medications, let's say an average of 5 medications with 4 fills yearly. Take those medications 2,000 to 3,000+ times a year. We give them variable information or suggestions about self-monitoring for blood pressure and glucose. We ask them to exercise on a regular basis and to come in for lab tests. So if you look at all these things, full adherence with all the things that clinicians commonly ask patients with diabetes and common comorbidities to do is a fairly complex regimen of self-management. Let me present this problem through 2 cases, both provided with informed consent. FJS is an elderly man with hyperlipidemia, coronary artery disease, and other medical problems. He's taken a statin since 1990 and has achieved an LDL cholesterol of less than 100, which is his goal. JFS, myself, is a research center director who inherited his father's lipid disorder, has taken a statin since 2006, and has also achieved a target LDL. Here's how FJS and his son would stack up according to this adherence cascade. My father loves to seek medical care. It makes him feel reassured and secure. I myself, as a physician, like most doctors, prefer to self-manage wherever possible. He keeps appointments because it gets him out of his apartment and he gets to see the outside world. I keep them when I make them. Making them is the hard part for me. Both of us are good about filling our medications. I fall off a little bit because I get busy and forget to call the pharmacy. We both take pills regularly. He uses a pill organizer. I miss pills when I'm traveling to talks like this, typically. He ignores a low-fat diet. He's discovered to his delight that he can eat anything he wants to, whereas I'm pretty good about it. He can't exercise given his age, whereas I'm pretty good about that. So the question really, if you look at all these behaviors, is are either or both of us adherent? And I think I raised this question to emphasize that refilling a prescription and taking a pill are not the same behavior. What I have to do when I refill a medication is to look at the label or count my pills, estimate how long in advance to call the pharmacy, call during working hours, and then eventually capitulate and see the doctor after repeatedly pleading for new prescriptions. When I take pills, it's actually simpler. I store them by my toothbrush and take them in the evening, but I have to remember to take them on trips. So these cases raise to me the question of which of us, my father or I, is more adherent, is the first question. And the second is, does it really matter, given that we've both achieved the goals of treatment? If we treat adherence as a single construct with multiple measures, as it's often viewed, then measures of adherence with all these steps, seeking care, keeping appointments, filling prescriptions, taking pills, and adhering to other self-care behaviors, are each of them a partial and somewhat imperfect measure of that construct as a whole. Some people might argue that taking pills is all that really matters, but most of us can think of health conditions for which medications are part of the adherence regimen, but by no means the only component of it. My notion of adherence is that it really is a set of behaviors, and that all of these behaviors are basically interlinked with each other. The importance of them may vary to different degrees for different health conditions, but that no one behavior and therefore no one measure constitutes a gold standard for adherence, because in my view, there is no such thing as an underlying construct of adherence. If you accept this argument, which is by no means the mainstream argument, it has a number of interesting implications for adherence research. The first is that the long-standing arguments about the validity of adherence measures are really all based on what I think is a false assumption that there is this underlying construct. Second, there have been many studies that show that measures of these different behaviors are correlated, but in some cases, as I'll show in a minute, they may independently predict outcomes. It raises questions about primacy. Which behaviors really affect the outcomes of interest? In the case I just gave you, pill taking seems to trump diet and exercise, at least with respect to achieving goal LDLs. This is obviously the source of the healthy adherer effect, which I'll talk about more in just a second. And it also suggests that interventions that are modestly effective in their own right, but that touch multiple behaviors, multiple levels of adherence, may, in aggregate, lead to cumulative benefit. I'm just showing a couple of examples of papers, one from Thorpe and colleagues in medical care, that looked at the agreement between refill adherence and self-report. These measures, self-report is a measure of medication taking, refill adherence is a measure of medication obtaining. These are particularly interesting to those of us in large delivery systems because both of these measures are feasible to collect in the course of routine care. They measured the agreement using a kappa statistic. Statistically, I'd argue that a measure of inter-rater agreement is not the appropriate statistical measure, but that quibble aside, the point here is that they were only modestly correlated with each other. But then in their multivariate models predicting blood pressure control, both a measure of medication refills and a measure, self-reported measure of medication taking, independently predicted the desired outcome of blood pressure control, suggesting to me that different behaviors need to interact, if you will, in order to achieve the desirable outcome. As many of you know, it's long been a source of interest that high adherence in randomized trials is associated with better outcomes, whether or not patients are adherent with the active treatment or even with placebo. And a recent systematic review suggests that this is actually a relatively strong effect, that placebo adherence is associated with better health outcomes. Certainly adherence with statin medications is associated with other kinds of self-care behaviors like adherence to screening tests, influenza vaccination, and the like. And there's even a problem in the field of healthy adherer bias in that people who respond to surveys about adherence when assessed by other means are actually more adherent than people who don't respond to surveys. So much of what we know about adherence and adherence measurement is actually based on samples that are biased with respect to the very variable that we are interested in studying, and that's largely because of the interrelationships between the various behaviors and the various measures of those behaviors. My colleague Ed Gardner, I, and others in the field of HIV several years ago proposed what we call a treatment cascade that outlines the importance of these behaviors. This cascade is based on the fact that if you compare the number of people who achieve the goals of treatment, who have undetectable viral loads, to the estimated number of HIV-infected patients, you see drop-offs at the level of several of these behavioral steps. Not all the people who are infected have been diagnosed. Not all of those who are diagnosed have been linked to ongoing care for their HIV. Not all of those who are once linked are retained in care. Most of those will need antiretroviral therapy, but by no means all of them receive it. And at the tail end of that cascade, some of those who receive medications do not still do not achieve undetectable viral load, although from this slide most will do so. The point here being is that efforts to improve adherence engagement with care, which is a form of adherence, may be one of the modest but partial and important solutions to achieving the overall goal, which can be achieved by moderate improvements in a series of small steps, rather than by massive improvements in any single one of those steps in the cascade. So what are the implications of this for delivery systems? To measure adherence and manage adherence at the population level, systems need to decide what behaviors to measure. And they should choose measures, obviously, that affect the outcomes they care about. Those outcomes most often consist of clinical outcomes, but Medicare STAR program has added a financial incentive to measure adherence as well. Obviously, we need to find accurate and efficient measures of those behaviors once we decide what they should be, and importantly, measure behaviors that the system itself can intervene on, and I'll have more to say about this topic. I think for a delivery system like ours, with 500,000 members, 100,000 hypertensives, the measures that are most feasible using electronic data sources are measures of appointment keeping and medication fills. I've written in other areas that the use of patient-reported measures of adherence, I think, is not far off. I think there are an increasing number of relatively easily deployed, simple measures that can be incorporated into increasingly sophisticated electronic health records to make self-report about medication taking a more feasible source for adherence measurement in large populations or health plans. Let me turn to the second misconception about adherence, which is that demographic and clinical characteristics could predict who will adhere and who will not. Studies that have tried to identify socio-demographic predictors of adherence also date back 30 to 40 years. The results are inconsistent. In some cases, older people are more adherent. In other cases, younger people are more adherent, and so on. If you look at the magnitude of effect for these predictors, they tend to have odds ratios of 2 or less, which means, as I'll show in a moment, that they're neither sensitive nor specific taken on their own. And adherence, as we've seen earlier, is a very prevalent condition. And as a result, you can use basic principles of clinical epidemiology to conclude that adherence differences between individuals with a specific risk factor, such as minority race, the presence of a mental health disorder, or even substance use, that the differences between those individuals in adherence and those without it are statistically significant at times, but not actionable. And let me illustrate this. I guess first I'll say that predictive models are all the rage. We're all in an era of big data, trying to use data that we have laying around the house in order to predict a whole range of clinical outcomes. But those models are only useful if they minimize misclassification and if we consider the costs of misclassifying somebody as either a false positive or a false negative. What I mean by that is that people who we classify as being, people who are adherent despite an adverse predictor, if we believe that they are likely to be non-adherent, we risk labeling them, we risk biasing our treatments, and offering them a different range of treatments than we would if we believed they were likely to be adherent. And I'll show some studies that support this in a second. Similarly, if we identify false negatives, people who are non-adherent, even though all their predictors are favorable, they're majority race, they don't have a mental health disorder, and so forth, then we're missing an opportunity to intervene in individuals who could truly benefit from an adherence intervention. This, in a simple 2x2 table, illustrates my point. The assumptions I've made here is that a non-adherence with any condition of interest is about 50%, that the prevalence of a predictor in the population is about 20%, and the relative risk for non-adherence of that predictor is about 2.0. I put in some sample numbers to show that under these assumptions, the sensitivity of that predictor is about 0.27. Its specificity is about 0.87. And the predictive value of this predictor when present is only 68%. And similarly, the negative predictive value is in the 40% range. And basic principles of clinical reasoning suggest that changes in probability from pre to post-test probability of this magnitude often do not affect clinical decision-making. They don't cross in themselves a clinical threshold. And if you look at the numbers of individuals who are misclassified under this situation, there are a certain number of people in whom a predictor is present who are adherent. That's the cell B, the upper right corner. 64 individuals are adherent. And there's a substantial number of individuals lacking a particular socio-demographic predictor who are non-adherent. Those are the individuals in whom you would miss opportunities to intervene if you focused only on predictors of adherence. And again, this I don't think is an idle concern. One study that suggests this was a national survey of HIV providers and patients in the late 90s. Basically, most of those physicians said that they based their treatment decisions or treatment recommendations on HIV meds on the likelihood of whether patients would adhere. And particularly those who were selective in recommending treatments to adherent patients were less likely to prescribe or were prescribed HIV meds later in the course of the disease to women, Latinos, and the poor than to men, whites, or the more affluent. And all providers prescribed later for African Americans than for whites. Now, if you believe, and I think the research supports the fact that African Americans are clinically no less likely to be adherent, or that the differences are not actionable, this suggests that people, based on an erroneous assumption about a predictor of adherence, might make very critical decisions that they would not have made if their prescribing decisions were blind to their beliefs about adherence. So what are the considerations here for delivery systems? I think it's fair to say that risk models to predict adherence based on the kind of currently available data that we have in electronic health record systems will not prove useful and may do harm. It remains an open question whether what we now think of as big data analytics will allow more accurate prediction of adherence. When we can measure patient attitudes, those traditionally have been stronger predictors of adherence, so there's some promise there, but these, as we know, are difficult to collect in the large scale. There may be other contextual sources of data that we can use to try to improve our ability to predict adherence, but the bottom line is why try to predict it when you can measure it directly? And as I've said earlier, I think that there are measures of important adherence behaviors that are already widely available in delivery systems. On to the third misconception, and I think this is the one that's actually the closest to being debunked, which is the traditional model back in 20, 30 years ago was that adherence was the responsibility of the frontline clinician, physician, nurse practitioner, whoever. I think we now widely appreciate the fact that improving adherence is what I would call a team sport. There's certainly evidence that office-based counseling by clinicians can produce modest improvements in adherence, but those interventions in general are intensive, hard to initiate, and hard to sustain. There's also good evidence that outreach through disease management, either in person or increasingly by using mobile technologies, can also be effective. But there's also suggestion that those interventions are most effective if they're done in coordination with clinical care and not, for example, by a disease manager based in an insurance company that isn't in regular communication with the frontline clinician. I think there's also increasing evidence that system-based and policy interventions can affect adherence at the population level. And as a health systems and services researcher, this is the area that I've really focused most of my work on over the years. Let me give you some examples of system-level adherence interventions, and I'll go through them in detail. Eliminating the Medicare donut hole, reducing or eliminating copayment for essential drugs, using mail-order pharmacies, and dispensing larger rather than smaller medication refills. Again, just looking at these before diving into the details, these are all decisions that are made at the policy level. The Medicare donut hole was actually a federal policy decision. The others are made within a system, either by the pharmacy or by others in the operational and administrative aspects of a delivery system. It's now been shown repeatedly that the Medicare Part D donut hole, whatever its other consequences, actually has been a barrier to adherence. As you know, the donut hole is a provision in the Medicare Part D law that establishes a coverage gap for Medicare beneficiaries who spend more than a threshold amount on their medications. A study conducted several years ago in our own institution found that adherence fell by 3 to 8 percentage points within an individual after that patient reached the threshold where they had to pay for their medications. This has been confirmed widely by other studies. It creates a really fascinating conclusion to me, which is that our elected representatives in Congress actually have a role in improving adherence. And in fact, they've taken steps toward that end, because abolishing the donut hole for Part D is part of healthcare reform legislation, but it's not scheduled to be implemented until 2020. So I think we have within that legislation an embedded barrier to the adherence of our patients or members. A long series of observational studies, and most interesting and recently, an important randomized trial have shown that reducing cost barriers can improve adherence. Many of you are familiar with the patient by Chowdhury and colleagues at Harvard that conducted a randomized trial of eliminating copayments for essential medications after a myocardial infarction. They found that refill adherence, when they did that, increased by 4 to 6 percentage points. They did not show a change in their primary pre-specified outcome, which was the subsequent rate of first major vascular events or revascularization and costs. They also showed no change in overall healthcare costs, but they did show in secondary analyses a significant reduction of vascular endpoints, the rate of total vascular events. And this finding, albeit a secondary finding of their trial, supports a vast amount of observational studies that also suggest that reducing copayment is associated with increased adherence, and in some cases with improved clinical outcomes. A number of studies in other regions of Kaiser Permanente have suggested that mail-order pharmacy reduces the barrier to adherence that's imposed when people have to stand in long lines at office-based pharmacies. A study in Kaiser Northern California showed that members who obtained mail-order refills were more adherent, first of all, and second, more likely to achieve LDL control. A further study showed by Elise Adams and colleagues that although minority members within Northern California Kaiser had lower adherence with new medications, these disparities lessened after accounting for both copayment and mail order use. In other words, that disparities could be actually alleviated to some extent by providing patients more convenient ways to access their medication. Now, I emphasize these are observational studies. To my knowledge, this has not been tested in a randomized trial. Such a trial would be fascinating, may or may not be something that a system would plan to do. But the best evidence we have at least suggests that reducing this barrier to adherence is associated with improvement in adherence, and in the one case with improvement in the outcome measure. This is figure from a widely ignored paper that I published over 20 years ago, early in my career. I was doing adherence research at that point in the VA system, and you'll see on the y-axis that I was studying adherence with a drug called digoxin, which we rarely use anymore. And I saw this fascinating phenomenon, which is that at several of the VAs I was studying, patients routinely got 30-day supplies of their medications. Whereas at others, they got either a mix of 30, 60, and 90 days, or in some facilities, they almost exclusively got 90 to 100-day supplies of medications. And if you looked at their adherence, it was dramatically different depending on the size of their prescription refills. If you looked at the subset of people who crossed over from large to small refills or vice versa, their adherence changed within person when you crossed over their prescription size. Now, there's a problem with this, which is that the day's supply is a component of the measure of refill adherence. So to some extent, this may reflect a measurement artifact. But other studies since that time, including one that we conducted in a safety net delivery system in Denver, suggested that larger supplies of statins were associated both with higher adherence and lower LDL cholesterols than 30-day supplies, suggesting again, albeit in an observational study, that larger prescriptions were potentially beneficial in achieving clinical outcomes. Another study from San Francisco recently found that providing a 1-year supply of oral contraceptives rather than, I believe, 1 to 3 month supplies was actually associated with a lower rate of unintended pregnancy. So the argument here is that while I don't think anybody would agree that the evidence for a larger prescription size is definitive, if you weigh the risks and benefits of this, it seems to be a relatively harmless intervention for antihypertensive drugs, oral contraceptives, and the like, whose net effect is to basically put medication in the hands of the people who need it. And so the risk is low, the benefit is at least possible, depending on your belief about the strength of the evidence. And this, to me, is yet another argument for a policy that healthcare systems could potentially adopt even more broadly to improve refill adherence behavior. So I think these sorts of findings have major considerations for delivery systems or comprehensive care models. Basically, they suggest that these systems can nudge change in adherence behavior. These are, if you've read the book Nudge, this is the kind of thing that they talk about in terms of choice architecture. By reducing out-of-pocket costs, either through reducing coverage gaps like the Part D donut hole or through reducing co-payments for essential medications, by enhancing convenience for patients, giving them larger medication supplies or allowing them to use mail order. Interesting research recently suggests that systems could provide brief motivational messages about adherence and have benefit. Other studies are increasingly suggesting that reminder calls telling people that it's time to refill their medications can increase adherence. The most recent of these being a paper by Michael Ho and my colleagues from the Denver VA Hospital who conducted a randomized trial in the VA system and showed that simple refill reminder calls had a very significant impact on cardiovascular disease medications in people who'd had cardiac catheterizations. So where do I think we should be going with system-based adherence research? I think there's a lot of potential in developing the kind of dashboard to monitor the adherence cascade at the population level that I showed several slides earlier has been developed for HIV infection. Identifying the denominator of patients in need of treatment, the proportion of those who are engaged in care, the proportion of those obtaining their medications, and the proportion adherent with those medications can help us identify several points at which adherence intervention is possible. As I said earlier, I think that self-reported measures of medication taking and of the barriers to adherence are being developed and validated. And much as we're thinking about how to report other kinds of patient-reported information, such as mental health measures, physical activity scales, pain scores, and the like, I think conceptually including brief self-reported measures of medication taking I think has the potential to become very commonplace in the next few years as the sophistication of electronic health records improves. A number of researchers are showing that e-health or m-health outreach interventions are useful, and I think the challenge there is to integrate those, as I said earlier, with other components of the delivery system to assure that our messages are, on the one hand, reinforcing, but on the other hand, are not burdensome. You know, if you have asthma and diabetes and some other condition and are getting 3 sets of e-reminders about filling prescriptions, we do certainly risk overburdening our patients unless we coordinate our messaging. Finally, and I think most provocatively, we need to do a lot more work to look at the relationship between adherence and outcomes. And the next thing I want to focus on is this question of whether the traditional 80% adherence threshold is clinically justified. Let's see, this is just another view of the cascade that I talked about earlier. Here is my point. I think many adherence studies have rather arbitrarily selected a threshold of 80% and higher adherence as good adherence when they dichotomize this essentially continuous variable. And I will say that the evidence base for that is remote at best. There were a study using about 10 years ago in HIV suggested that 95+% adherence with that generation of antiretroviral drugs was necessary to achieve an undetectable viral load. And this suggested at that point that very high adherence with antiretrovirals was necessary to achieve clinical outcomes. A very old study conducted, well, you can tell how old it is by the topic, the study was conducted in the 50s on prevention of repeated streptococcal pharyngitis in people who'd suffered acute rheumatic heart disease. This study suggested that patients only needed to be roughly 30% adherent with prophylactic penicillin in order to reduce their risk of recurrent streptococcal infections. So this kind of evidence, and I'm just mention a couple of examples here, suggests to me that the relationship between adherence and clinical outcome may be actually disease-specific and drug-specific. In some cases, it may be linear. I actually believe that that's true for statins. In other words, that based on some of the work we've done, that increasing a person's adherence with statins from 50% to 60% will probably benefit them, even though they don't reach an adherence threshold of 80%. It's probably also true that increasing their adherence from 80 to 90% will reduce LDL even further. But there may be, as this slide suggests, a linear adherence outcome relationship for some conditions, rather than a threshold effect, which I show by that sort of curvilinear relationship in the other part of the diagram. So as I've said, I think that there's a lot more work that needs to be done in this area. Actually, I'll go back to that slide. Largely because if individual clinicians or if delivery systems are going to invest more resources in improving adherence, we should not tell them only when to start, but frankly when to stop. If there's a level above which additional adherence is unlikely to produce additional gains in clinical outcomes, the cost and effort could be better directed towards other goals. If 80% adherence is good enough, then increasing adherence from 90 to 100% is a waste of effort, may even be a waste of medications. So I think that further investigation of this sort of relationship between adherence to outcomes is actually a critical part of the adherence agenda. So a few final thoughts. While most of the research over many years has focused on more one-to-one kinds of adherence interventions between an adherence counselor, be it a physician, a pharmacist, a nurse, or who have you, and a patient, I think these system-level interventions in aggregate may be the least expensive to initiate, the most scalable, and the most sustainable because they don't require the sustained conversations that one-to-one adherence interventions require. I think as high deductible health plans have become more widespread in an effort to contain healthcare costs, I think it can be predicted that those are going to have an adverse effect on adherence behaviors. And I think research in that area is certainly warranted to basically assure that high deductible plans are not in some sense penny wise and pound foolish. The widespread implementation of primary care medical homes provides the coordinated integrated care that I think is likely to improve adherence, but as yet I've not seen studies showing directly that primary care medical homes can improve adherence. I think adherence will be a good marker for the effectiveness of those reorganizations of the delivery system. The kind of coordination between office-based adherence intervention, outreach by disease management teams, and system-level interventions such as changes in pharmacy policies, to coordinate those requires communication and informatics tools. There's evidence for other kinds of disease management interventions that disconnecting them from the clinical environment really mitigates their benefits. And so using the electronic health record and other electronic data systems to make sure that everybody has the same information base, I think is an important thing that many systems still need to achieve in order to coordinate their interventions to improve adherence. So having said all that, I'll just finish by stating that high adherence at the population level is clearly possible. Several organizations, among them many integrated healthcare delivery systems, not only Kaiser Permanente by any means, and other organizations like the VA, have shown that it's possible to reach and sustain high medication levels of medication adherence for large populations of patients. I think the real challenge now is to figure out how to adapt and deliver those interventions to the less integrated components of the healthcare system, either in the traditional fee-for-service system or in the safety net. And with that, my presentation is done, and we have a few minutes for questions.
Absolutely. And so, as I understand it, you can be typing in your questions through your online screen, and as soon as we see them, we'll get them to Dr. Steiner and then have him try to respond to them in the time that we have. Are there any questions that are queued up?
Yeah, could you?
Okay, so the first question is, can packaging strategies such as, I think this is calendar packed versus loose tablets in a bottle and reminder containers, so MEMS caps, glow caps, help improve adherence?
Yeah, I think there's accumulating evidence, although it's not entirely consistent, that better ways of organizing pills can also improve adherence. I think electronic pill caps like MEMS caps or others have largely been used for their measurement properties to really look at day-to-day adherence in a very granular way. I don't work with these systems individually, but my understanding is that the companies that market them are really developing the potential to do outreach and other sorts of reminders. So I think that's also another approach that deserves more emphasis and more study. I think the barrier to widespread implementation of such devices, which have been around for really decades now, is their cost. And again, I think any intervention in a delivery system needs to meet the challenge of scalability to 100,000 hypertensives, half of whom are non-adherent. So that's not a unique challenge to any particular intervention, but a common challenge to all of them.
Thank you. All right, so the next question is, if one makes a system-level change of increasing the amount of drugs supplied, how does the provider team ensure adherence to clinic appointments? For example, our patient population seems to return to see us when they need their refills.
It's a really good question, and it certainly raises the possibility that not all adherence interventions are synergistic, and some may in fact be antagonistic. I think that there's a whole range of ways to address that. I think in some respects, if you use obtaining refills as an incentive to see the doctor, you're using that as a way to do other components of the care that you want to deliver. If you were looking only at medication adherence in isolation, you might argue that longer refills are more helpful. But there's obviously a whole range of other things, from care of acute conditions to other chronic health conditions and other things that need to be done face-to-face. I think we're looking in a world in which the primary care delivery system is increasingly understaffed and overburdened. I think we do need to look for ways for taking things out of the hands of frontline clinicians that can equally well perhaps be done remotely or by other means. But I think it's a good question in the sense that you have to consider the ramifications of these interventions, not just on adherence with one medication, but on your overall goals of care for that individual.
Excellent. I have one question that I'd like to ask. So you talked about how important it is to get away from this arbitrary 80% mark and really understand, the relationship between level of adherence and disease outcomes. And I'm thinking about, pharmacy data, and that there's going to be self-reported adherence data now in these integrated delivery systems. I mean, are you or other groups, are they doing work to take a look at levels of adherence and the relationship to disease outcomes?
Yeah, we certainly are, and I'm sure that other groups are as well. Much of the evidence I've provided in this talk is from observational studies, particularly in large populations. I see this kind of adherence research as a subcomponent of comparative effectiveness research, because I often say that why adherence fascinates me so much is that it shows that patients have a veto power over our recommendations. And so a medication can't be effective if it's not taken. And I think, therefore, adherence assessment and improvement is a critical component of the whole comparative effectiveness research agenda. I think the research can be done, but there's certainly the biases that need to be addressed in that, as I've suggested. I think the healthy adherer effect is clearly problematic here as well, is that if you use only refill adherence as a measure, for example, and don't control for other kinds of behavioral interventions or behaviors that affect the same outcome, you might misspecify the relationship between refill adherence and the clinical outcome. Mm-hmm. So it's an area that I think is very important. I think largely that work won't be done through randomized trials, but as all observational studies, the sources of bias are going to require careful attention.
I agree.
Hi, John. This is Mike Sterrett from the Division of AIDS Research at NIMH, and thank you for your great talk and all your great work in this area. The question I had was about the role of counseling interventions to support adherence. I think you make a very persuasive case for nudging adherence behavior through these systems interventions. But implicit inside of that, especially with this idea that there might be a point-of-care self-report assessment of adherence, is that if we're feeding this information back to providers, back to clinics, that might be actionable information, to then take and to do something with individual patients. And so I guess I'm just wondering about, is that complementary then, kind of working with individuals while also dealing with the larger system? Or what's your view on those kinds of counseling, individually leveled interventions?
Oh, absolutely, they're complementary. Again, another analogy I sort of think about is cancer chemotherapy, where you've got multiple points in the disease process that different treatments will intervene. I think the same is true for this, and as you know probably better than me, many behavioral interventions, is that intervening at multiple points is probably more effective than intervening at one alone. I think the challenge with counseling interventions is how to integrate them into care. All frontline primary care clinicians complain about shrinking appointment times and increasing agendas of activities. So I think interventions to work in frontline settings need to be very brief motivational interviewing kinds of tools are one area. But I think integrated care works best when every member of a care team is singing the same song. And I think providing information to clinicians alone without instructing them how to talk to individuals about that may not be helpful and may also be counterproductive if the clinician approaches the issue in an accusatory way. So I think that, I don't take this term integrated lightly. These systems call themselves integrated systems, and I think what integrates them is their capacity to integrate interventions across multiple levels, across the policy level, the outreach level, and the frontline level. But absolutely, they're complementary.
Okay, that's a couple more. Okay, we've got 3 more minutes, so there's one more question that came in. And so the question is, can you speak to how approaches may be adapted? So I think the approaches that you were talking about today, maybe mail order pharmacy and some of these other things, be adapted based on the system. So I think it's looking at generalizability to other systems, HMOs, federally qualified health centers, academic medical centers, and what your thoughts are about that.
Yeah, that's a really critical point. I've been working in Kaiser enough to hear many times the critique, really. Well, that's really great that it works for you, but you guys have this entire infrastructure that really supports this. I will say that I think that at the broadest population level, this problem is really not going to be soluble without a lot of increasing care integration. But you can see a lot of the things, even in the private practice setting, that are pushing us in that direction. Health information exchange, for example, all the HIE interventions that have been conducted across the country. One of the components of that, of course, is potentially transfer of information from pharmacies to frontline clinicians, even outside integrated care settings. Certainly, the use of electronic health records to measure appointment keeping and that kind of thing. Many of those applications meet the kind of meaningful use standards that are being set for using electronic health data to actually improve care. I think I alluded earlier to the concept of the primary care medical home, which is really integrating a care team into the frontline setting. And I think even linking in a relatively small group frontline clinicians and the counseling that they can do with the work that their nurse or their diabetes educator or whoever they have, their mental health worker, whoever they have in their environment, clinical pharmacist, which is an approach that Kaiser uses with great benefit, integrating those professionals into care, asking them to deliver the outreach messages between visits has great promise, even if there's no links with the pharmacy system. Non-adherence is prevalent enough that you can assume that by and large patients will appreciate your contacting them even if they are taking their pills, and the 50% who aren't, you have a potential to help. So I think many of these tools are adaptable outside a fully integrated model of care.
Right. Thank you so much for a wonderful presentation, the time you took to answer the questions. I just got a list of a bunch of new questions that we don't have time to answer, but we thank you for your engagement and hope that you enjoyed this session and you'll attend other Adherence Network webinars in the future. So thank you very much.